infections. Is my voice clear to you all? Is my voice clear? Well, then there are other specialties will start afterwards by my colleagues, but we'll be continuously going covering because we realized even today Vice Chancellor informed me that we have to be very active in teaching and learning and testing also all go together during the course because surgery is the second most largest subject in the final year. So a lot to read, lot to do, and lot to test also, right? So a lot of self work, self activity, self reading need to be involved here, right? So we'll do this normal MCQ, this format, and after that, I will go through uh, some clinical cases, right? So, can somebody come and answer this? This is regarding bone infection, tuberculosis of bone. Anybody? A. What's the answer you think? Sorry?
False.
Wrong. Vertebra, that's right. Yeah, yeah. Vertebra is the most common bone to get involved, vertebrae. That's called what? Whose disease is that?
Pots.
Pots disease.
Pots, yeah. B. Global resurgence is mainly due to?
True.
It's not exactly true. Resistant strains contribute a lot. I mean, it's contribute a lot. But of course, many other factors like malnutrition and other things. But mainly it's due to HIV. HIV, because as you know, many HIV people have various types of tuberculosis. May not be mycobacterium, but other multi-drug resistant ones, or even other ones. So it's mainly due to this HIV which upsets because you know a lot of fairly significant number of global population is involved in HIV, although we don't realize. What we see in Sri Lanka is also tip of iceberg. In South Africa, I think it's about 1 in 8 people have HIV. So that's the main reason. C. Anybody? Hello? Anybody?
False, sir.
Yes, it is false. It affects the bodies, but not like septic arthritis. Septic arthritis is different. It attacks discs quickly because they have proteolytic enzymes. So the likely reason given is tuberculous bacteria doesn't have the proteolytic enzymes like in strep, staph, those bacteria. So it affects discs late, and but this can get destroyed because either side the bodies can get destroyed. So finally, this also can, you know, get the destruction. D. PCR has superseded culture in management.
Never. Culture is the best. Affecting the body.
Yes, it is true.
PCR has made the major changes. You can quickly get the result, but problem is it doesn't say whether patient had TB or still has. There is an issue about that, whether active TB or not. If there are active TB or not, it doesn't say. So culture is still the gold standard, right? Culture. So you can't say PCR has superseded culture in management. Superseded means that it has become the gold standard. Still, the culture is gold standard that gives active disease, and it affects antibiotic sensitivity and many things. Leads to cold abscesses.
Yes, true.
True. What is the most famously spoken site of cold abscess?
SARS.
psoas, yeah, in the groin, isn't it? In the groin, where it can come to differential diagnosis. Well, Pott's disease, it travels from the vertebrae to groin, and it can come into differential diagnosis of famous other lumps in the groin. You know, it's a famous short case thing, lumps in the groin, the hernia, lymph node enlargement due to whatever the reason, femoral aneurysm, femoral hernia, inguinal hernia, and say universal lumps, that is lymphoma, lymph node, and sebaceous cyst. And this also, cold abscess also, one of those lumps. You know, lump in the groin, that's a typical, what do you call, short case, right? Lump in the groin. So you have to think of all these possibilities when the patient has lump in the groin, like lump in the right iliac fossa, epigastric mass. Those are, or acute scrotum. They collect a group of conditions. So you must know what are common of these conditions, what are the serious conditions. And in your clinical practice and in the exams, you think in like that way. Okay. These are the answers. I'll give you a minute to go through that. Okay. Uh, so how does a TB present to a surgeon? Can anybody tell me 10 ways a TB patient can come to you if you are in surgical ward or you are a surgeon?
Back pain.
Yeah, very good. Back pain. It may not be just the pain, you might have paraplegia even, isn't it? Sorry? There is some music. Back pain, what else? Anything else?
Lymph node enlargement.
Yes, lymph node. So mass in the neck or other parts. Yes. Or sometimes it's abdomen.
Fistulas.
Yes, perianal fistulas. You're right. Perianal multiple fistulas you can have due to tuberculosis. What else?
Right iliac fossa mass.
RIF mass. Very good. Very good. It's
Nerve entrapment features.
nerve entrapment features. Yes, that's called equina-like, isn't it? So in the spinal disease. What else? Lung mediastinal mass. It can cause hilar lymph nodes in the mediastinal mass. So that's one. And it can present with tuberculous peritonitis, which is sort of more of a milder form of peritonitis, diffuse abdominal tenderness and things, what is known as DOI abdomen, right? What is known as DOI abdomen, right? That's an important thing. You read about DOI abdomen, and of course tuberculous ulcer, which is known as lupus vulgaris. Then tuberculosis of kidneys, which can cause tuberculosis of kidneys, which can present as hematuria. So it's a differential diagnosis of the presentation painless hematuria. Sorry. And if it affect the testis, you can have what's called enlargement of testis. This is not acute scrotum, but enlargement of testis. Causes can be syphilis, leprosy, or chronic epidermolysis, where there won't be much pain, and testicular tumors and testicular TB. So these are the situations where testis is enlarged and it's chronic. It's not an acute condition. Of course, tumor should be the first in your differential diagnosis, but you have to consider all these things, right? So there are many ways how they can present. Cervical sinus is one, what is called collar stud abscess. Then we'll go to the next one. Okay. Can somebody answer these things?
True.
Yes, night sweats. B,
True.
true, loss of weight, good. C,
False.
False.
false, yeah. ESR should be of much higher, 80, 100, some in that range, okay? So ESR over 80, you have to think of certain conditions, tuberculosis, multiple myeloma, metastatic malignancy. There's a thing called Waldenstrom's macroglobulinemia, you may remember from your pathology. So there are relatively few conditions which can lead to very high ESR, right? So you must know that group of diseases. D, what's the answer? Hmm? Correct? Anybody?
False.
False. Because this is very high. This is typical of septic arthritis, which comes into differential diagnosis. It will be less than 3,000 in TB. E is
True.
true. We are correct. In true, the joint become deranged and weak, and the patient is immunosuppressed also due to disease, as well as the steroids, which we often use, steroids or some things like various anti-cytotoxic drugs. So patient become immunosuppressed and in the disease joint, so it can invite are more prone to tuberculosis. So anybody with arthritis is more prone to tuberculous arthritis, okay? Because arthritis make a joint weak and defenses poor. So any kind of even osteoarthritis can increase the risk of somebody getting tuberculous arthritis. Answers you can go through. What are melon seed bodies? A person who can answer. What are melon seed bodies? Have you heard of them? They are actually calcified, certain small calcified nodules, like floating things which occur in bursae. Bursae, when they get involved by tuberculosis, actually they occur commonly in the palmar bursa. You know, there are two bursas here which can get involved in TB. The palmar bursa, you see these calcified bodies inside. Palmar bursitis due to tuberculosis. You get melon seed bodies. People ask about these things, so you must know what they are, right? I told you in surgery, when you are asked about something like this, you must at least know that I have never heard of කියන්න අමාරුයි. එහෙම හොඳ නැහැ. හරි? ඒකයි that you have to learn a lot of new words. At least basically describe what it is. Right? So treatment of tuberculosis is the same as septic arthritis. You aspirate initially, then you do for culture and all that. Immediately you drain, you open into the joint, irrigate and drain, and then you close don't close the joint capsule, just but close the skin. You would not insert anything. So you open into the joint, you wash the joint, take for culture, cytology, everything, and then you come out without a drain. Never leave a drain inside the joint, but also don't stitch the joint capsule. You come out and you close the skin though. So what will happen is this muck will come from the joint, the cavity, through this hole in the joint capsule to subcutaneous tissue, and it will be absorbed by the lymphatics there. That's the purpose, right? So that's like septic arthritis or TB, it's the same thing. And after that, there is a very important regime in people who had treated septic arthritis. The regime is that you must never let them weight bear for 6 weeks. No weight bearing for 6 weeks. And after that, you can allow partial weight bearing for another 6 weeks. And it's only after 3 months you will allow significant weight bearing, because synovial membrane is damaged by septic arthritis and it's very fragile. So you have to allow it good time to heal. So it will take around 3 months, I think, to heal totally. So absolutely non-weight bearing for 6 weeks. And also 3 weeks, you have to immobilize it, the joint. in the POP back slab, right? So I'm going through it again because it's a very common thing. It's an emergency. Septic arthritis or tuberculous arthritis, you drain, wash the joint, close the skin only, not the capsule. Then your further management, in addition to your drug therapy, which may be antibacterial or anti-TB drugs, 3 weeks full immobilization of joint in the POP, non-weight bearing. Another 3 weeks non-weight bearing, but you can mobilize the joint quickly. Right? And then another 6 weeks, altogether up to 3 months, you would up to 3 months you can do partial weight bearing. But can you off your mic? Some it's bit little disturbed, huh? Right? So, but some surgeons would mobilize from very early. They will not weight bear certainly, but they will allow exercises happen a little bit earlier because knee can get stiff or joints can get stiff very quickly, right? Right. Now, next question. Can anybody answer? Can somebody come and answer?
A, true.
True. Yes. And B.
True.
True. Yeah, it can present fever. C.
True.
Yeah, layers of periosteum. Periosteum get elevated, laying down layers of calcium. Every year it happens like that, that kind of appearance. D.
True.
True. Yes. You have other forms also of chemotherapy, but radiotherapy is the main thing. Yeah. E.
True.
True. Well, 10% has spread to other parts at the time of diagnosis. It's more than that. About 25 to 30% has spread to other parts at the time of diagnosis. Okay. So it's this used to be a bad tumor, Ewing sarcoma, right? So it normally affect long bone. It's different that it affect diaphysis, right? It affect diaphysis, not like other tumors, and it present with fever. It can present anemia and high ESR. So it's treated by radiotherapy. Yeah, initially first you give chemotherapy for this Ewing sarcoma, and then surgery or radiotherapy, depend on the situation, depend on the accessibility, right? So chemotherapy first, followed by surgery or radiotherapy, right? 10%, so it's 25 to 30% 5-year survival for localized disease. So now with the modern regimes, if the disease is only localized, that means it has not metastasized, about 70%, right? 70% 5-year survival rate with modern treatment. But in fact, the prognosis can be much less. So this is not a very good tumor. You have to diagnose quickly and handle very carefully, right? And so, can somebody come and answer this one?
True.
Yes. B.
True.
True. C.
True, sir. That's true.
Well, there's an issue there in the wording, right? Unique. Unique means it's only for that. Okay. So sunray spicules are different thing. They are actually evidence of rapid expansive growth or elevation of periosteum, rapid elevation of periosteum, or expanding growth really. So it's not only occur in osteosarcoma, any rapidly expanding tumor or even infections where there is a quick swelling and expansion of the cortex. It can occur. D,
True. True.
yeah, it's true. Paget disease is a risk factor. There are many other risk factors. E, anybody?
True.
It's wrong actually. Intra-arterial chemotherapy, right? Not intravenous. This is situation osteosarcoma. They are vascular tumors. So intra-arterial chemotherapy is the main thing. Okay, you have to think of it in that way. So answers around knee, it occurs in about 60% of the time. That's lower femur or upper tibia, and upper humerus is again a common place. So sun ray spicules are not only unique for osteosarcoma. It has other things as well. You know what you mean by Hodman's triangle. I'll try to draw in this makeshift thing. When then the say bone is there, right? Let's hope you can see that periosteum got elevated, right? And Hodman's triangle is you deposit things here, and they lay down this bone spicules, the sun ray spicules. Okay. So just give me a minute. Right. So next question. Somebody? Osteoclastoma. The other name is giant cell tumor of the bone. Anybody?
True.
Yes, vast majority are benign. Actually, less than 5% are malignant, about 5% or less. B,
True. True.
true. Yes, actually, any of these bony tumors, whether benign or malignant, can present with a pathological fracture. Okay, so any of the bony tumors, benign or malignant, they weaken the bone. That's not normal bone, right? They always weaken, so they can present with pathological fracture. C,
That's true, sir.
that's true. Yeah, yeah. D, this is for somebody who go for distinction. Okay. Solendronate, but you can
False.
false. Yeah, that's right. It has a different way of action, isn't it? Solendronate is a different thing. What does it do?
Bisphosphonate.
Solendronate, what do they do? How do they act? This group of drugs.
It's a first generation bisphosphonate. It binds with the binds with the damaged bony surface of the bone and then reduce the demineralization of the bone.
Yeah, osteoclast. It action on osteoclast activity. It reduces the action of osteoclasts. Right. So as you said, it's when osteoclast action is inhibited, but it reduces demineralization. Yeah. E, correct? What do you think?
False.
false. Yeah, there are many other tumors, including both benign and malignant ones, like aneurysmal bone cyst or osteosarcoma. But I think 5 or 6 other tumors which which have giant cells. Right. Just a minute. I want to call. Satish, hello. Oh, yeah, that's all. Oh. Then ETCFK ඇත්තමට මේ වෙලාවේ නම් I'm not sure if the patient is in ward 5. I'll ask my HO to call you in a minute. Yes, that's right. Yeah. Oh. Oh. He's very, has one with many medical problems, diabetic, bad diabetic, poorly control, all that, and cardiomyopathy, 20% ejection fraction, right? Then, yes, yes, yeah, okay, yeah, okay, right, thank you. Right, so let's go through the answers. So sometimes they metastasize to lungs, but even they can be benign because once you remove the primary tumor or respond to treatment quickly. So they are called, it's a funny thing, a benign metastasis, right? They use that. So if they have a pathological fracture, however, the treatment becomes complicated because then you want to remove this tumor surgically or give radiotherapy or whatever. You can't do that when a patient has pathological fracture. You have to wait till fracture heals. And you don't want to do any operation to make fracture heals because then you will mess up the area. Okay. So you immobilize the joint, immobilize the bone. That's the only way till the fracture heals. And then you do your surgery or radiotherapy or chemotherapy, whatever, to that. So the point is that you must suspect these people, do X-rays, find them before pathological fracture occurs. Find them before pathological fracture occurs and treat them before that occurs. Then this problem will not come up. That is treatment getting delayed because until the fracture is healing. Because if you start treatment, fracture will not heal. So you must, these are the things like principles in management you have to be aware. This is the game. This is why you must have be suspicious and diagnose things early before things go out of hand. In fact, one person, Dr. Satish, just spoke to me on the phone. That's a patient who had a small hand infection, many medical problems, small hand scratch of the hand, and whole area developed massive cellulitis. And patient then it was decompression, which was delayed in presentation. Decompression was done also, it was late and it was not complete. So as a result, necrosis and things continued. So we have a big problem in our hands now because of delay in diagnosis and delay in management. Okay, you must do the right thing at the right time. Also, anything delayed is treatment delayed is treatment denied. Right? Treatment delayed is treatment denied. So diagnosis delayed is diagnosis denied and treatment denied. So solenoid act by increasing apoptosis of giant cells osteoclasts, and denosumab takes the target rank ligand. So these are a bit hi-fi stuff, I know, but if you know, it's better. Then in a suitable situation in the exam or in life, of course, it's anyway important. You can, it will be useful to you, right? More knowledge doesn't do anybody any harm.
True.
Yes, it is true. B.
True.
True. Yes. So older person presenting with back pain, these are the things you have to think of. Multiple myeloma, secondary metastasis, probably from prostate or some other things, and expanding aortic aneurysm, They are into important and common DD, differential diagnosis of a back pain, right? So this is something you must consider multiple myeloma in all people. C, pepper pot skull X-ray with holes in it, right? On X-ray. That's a characteristic feature of multiple myeloma. ESR,
True.
well, over 60,
It's more than
it
that,
should
yes.
be over 100, really, 120 years. Actually, this TB and these things, ESI is over 120, how about 100, 120? That's what they say. 60, 60 can be anything, really, right? So in the MCQs, when you're answering, somebody might argue, somebody, pedantic people who go by letters, words, they will argue that, well, over 120 is over 60. They will say that over 120 is over 60. So it's true, but it's not the case. Okay, you must look at the spirit of the question. Why the examiner said this question is that many conditions can increase things into this range, but multiple myeloma is one of those handful of conditions which can give very high ESR. That's over 100, 120, right? So spirit of the question බලලා තමයි උත්තර දෙන්න ඕන. හරි? E. E. What do you think? Anybody?
True.
It's not true. Right? Let's see. Yeah, it's not true. You can see this, right? Answers, it's 30% about. Although we think this monoclonal gammopathy is one which leads to myeloma band and Bence-Jones protein and those things are connected to that. But it's about 30%. It's not all that common, right? So it's a group of features we consider together. Uh, Group of features we consider together, right? Anybody?
All.
It's a secondary malignant tumor of the bone. A, kidney is a common source. Have you heard of now? This is a situation where primary is somewhere else. Okay, primary somewhere else. You get secondary malignant tumor, second deposit, basically metastasis is in bone. Can you remember this benzene structure? Famous benzene ring story. It happens from thyroid, breast and lungs, then renal and adrenals on the other side, and prostate. Okay, so that's a benzene ring structure. From those areas, it's common for the cancer to come to bones, right? It's common for the cancer to come to bones, right? Uh, B. Uh, it's not true. Lung cancer has associated with enlargement of wrist. That's called hypertrophic pulmonary osteoarthropathy, right? That's a paraneoplastic thing, right? Not due to secondary deposits. Lung cancers can cause deposits elsewhere. Yes, true, in the bone or anywhere. But enlargement of wrist is due to paraneoplastic thing. Have you heard of that? No, hypertrophic pulmonary osteoarthropathy. Then C. What do you think?
False.
C, secondary deposits, secondary malignant tumors in the bone are usually lytic. It's true. Rarely sclerotic. When do you get sclerotic secondaries?
Prostate.
Yeah, prostate and sometimes breast or colon. Okay. Present with pathological fractures. Yeah. Managed by local radiotherapy.
True.
True, yeah. It reduces pain when you so local radiotherapy is one of the methods. It's a kind of palliative, real, isn't it? In this stage, it's palliative and it causes pain. So you can go to the
Sir, can you please tell again what is the benzene ring
all right,
distribution?
benzene ring is if you find secondary deposits in the bone, you know, the secondary deposit in the bone is a very common phenomenon. No? So, I mean, almost any cancer can metastasize to bone. No? Lung, liver, bone are three common areas where a primary tumor from any side of the body can metastasize, right? But most common tumors to metastasize to bone are from this, it's a mnemonic really, benzene ring tumors. Benzene ring කියන්නේ මෙතන there you have thyroid and then you have breast and lungs, then renal and adrenal and prostate, the lower part of the benzene ring. හරිද? You are okay?
Okay, thank you, sir.
Okay. It's a very important thing to remember. That's right. A common thing you have to remember. Sorry. Answer this one.
True.
Yes, you are correct. In children or infants especially, it's mostly due to heterogeneous spread from respiratory, urinary infections and ulcers. B,
False. Salmonella.
yes. C,
True.
true, they do. But that effusion is called sympathetic effusion. Sympathetic effusion can, when there is inflammation in one area, because of that inflammation in that part, there is hyperemia, and as a result of hyperemia, you have more secretion of the fluid into the joint. So that's called sympathetic effusion. So in this situation, you have a problem. One is we have to differentiate this warm, red, swollen joint in this person from septic arthritis, isn't it? The management is different because sympathetic effusion, you would not do anything. You just treat osteomyelitis only. So how you differentiate is if patient can move the joint, right? Patient can move the joint a little bit or somewhat with sympathetic effusion. But if you have septic arthritis, even this much of movement will not allow. Severe pain, muscle spasm will not allow. Patient will cry, right? D.
True.
Yes. Yeah. Up to 2 weeks, it can be normal. E.
False.
False. Yeah. For infants, in children and infants, very rarely you need surgery. So you give fairly long duration of 1 month or 6 weeks of antibiotic therapy, and we can manage with that. Answers you can go through. So osteomyelitis, the last one you get from when you say acute, that's under 2 weeks. Between 2 weeks and 2 months, it's called subacute osteomyelitis. If it is more than 2 months, you have to call it chronic osteomyelitis. So if it is acute, even in adults, you try to give IV antibiotics and managed by it alone, right? That's the best way, no? If it is less than 2 weeks. If it is more than 2 months, no point, you have to do some kind of surgery because these stages, you have cloaca, you have involucrum, sequestrum, hmm, probably abscesses around the bone, uh, as we said about malignancies, sunray spicules and Codman strangles and things. So a lot of things have happened. You have to operate. If there's sequestrum forms, there's no way you have, that's a dead bone. You have to, within the bone, so you have to break the bone and remove the sequestrum and put gentamicin beads or irrigate or do everything. So it's a big, big job, right? Chronic osteomyelitis. It's lifelong unless you have to treat it, do something. You have to remove that part of the bone and do bone migration or put artificial bone, something like that. Uh, so it's a lifelong problem, chronic osteomyelitis, right? So the time duration is very important. You must remember the time duration, right? Less than 2 weeks acute, 2 weeks to 2 months subacute, more than 2 months chronic. So chronic is like surgery is needed very often in addition to antibiotics. Acute you manage just with antibiotics. You try to manage just with antibiotics. That is 1 week IV, as I mentioned, and 3 weeks oral. Now about the subacute group, what we do is if it shows bony changes, like I mentioned before, sequestrum, involucrum, Codman strangle and bony spicules, sunrise spicules, all these things, then you will have to treat with surgery. But if it is subacute, doesn't show bony changes, then we try with the same regime like acute IV antibiotics probably for about 2 weeks, then give more another say 4 or 8 2 months up to 2 months of oral antibiotics, longer duration of oral antibiotics. So now, have you got the basic principle in managing acute osteomyelitis? Basics. You understood?
Yes, sir.
Okay, good. Somebody answer.
A, true.
Yes. B.
True. That is because of the cartilaginous damage.
Yes, you're right. C. It's true. Okay. Initially, it enlarges due to increased effusion, but later with chronicity, the joint space will be narrowed because cartilage get destroyed and all that. But initially it enlarges. So this is the way in children, like if you are suspecting septic arthritis of hip, which is a deep structure, we can do ultrasound and find out whether there is a increase in joint space. So if we have increase in joint space in the hip, we know that patient has effusion there, and that means in the context with fever and ill child not moving the limb, that will be septic arthritis. D.
True.
True. Yeah, this is, I have told you, I think, this is something you would not wait till the next day. This is something you will not wait till the next day. You do same night. When a patient is septic, if suspect, you do it in same night. I know this is not happening in our hospital all the time due to many different reasons, but it's wrong. Okay. So because if we mismanage, this person is going to suffer with limp and aches and pains, osteoarthritis. It's basically life can get crippled. Okay. Especially if a child, young man, anybody, I mean, life can get crippled. So this is something you do within the next few hours, arthrotomy and drainage, in addition to starting IV antibiotics. E.
False.
False. Answers. So osteoarthritis treatment, people inject, right? When you, a lot of GPs, general practitioners inject a steroid into this joint. Okay, it will buy about 1 year's time, right? Around 1 year's time. So you may repeat injection once or twice, but it also destroys the joint earlier, quicker, because putting steroids does that damage to the joint. But the thing is, when you inject, there's only one way to inject, that is inside the operating theater, clean and draped. You don't have to give anesthesia, probably a local anesthesia might help. But inside the operating theater, clean and draped, just like you do appendicectomy or some surgery like that, or herniatomy. Clean, drape yourself in full gear, like a normal theater thing. Then only you inject this injection, right? So that's because even one bacteria going into the joint is bad news, because joint by itself, joint cavity is meant to be sterile by God, right? Meant to be sterile. So it can't cope. It doesn't expect problems. It can't cope with the infection, not like a normal skin. Okay, it can't cope with the infection. Uh, so that's that, right? So you understand, injecting a joint is not a simple thing, right? Even in England, people inject joints in the clinics, and but that's bad. That has a risk. This, it's not uncommon for this sepsis to happen like that, right? Sorry. Then when we give antibiotics, right? The problem with septic arthritis and osteomyelitis, we give antibiotics intravenous. When to stop and go oral and possibly discharge home, because we can't keep these people in the wards for weeks or months. So our guide is ESR and CRP. This is a practical point. Please remember, our guide is ESR and CRP. Once you give IV till ESR and CRP come to reasonable level, say it may not come to normal, but say ESR come to about 15, 20, even 25, to that range is okay. You give IV antibiotics till then thereafter you can discharge the patient on oral antibiotic, because they have to be on that for 6 weeks, 2 months, sometimes even longer, right? So be clear about the management of these conditions. If you have any worry, you can ask me, right? Can somebody answer this question?
A false.
True.
It's true, really. Now, maintenance means, like economy, maintenance is depositing bone and removing bone, right? So fibroblasts and things, osteocytes like them, they stabilize, they maintain the bone. Osteoblast form the bone. Osteoclast remove the bone. So all these three are in equilibrium all the time in the bone. Bone is a very active thing, although you think it's deposited, that's there like a structure of the house. You think like that, but it's not. It's dynamic, active thing. This happens all the time, every minute in all of us, whether young or old, right? That's the sorry, that. Then B,
Diaphysis and epiphysis.
sorry, between metaphysis and epiphysis.
It has to be diaphysis and
Sorry? No, it's true, isn't it? So, C.
true.
True. Yes. Then nutrient artery is directed towards elbow. Why is that?
Away from the growing end.
That's right, away from the growing end, no? Because it grows from here. You can remember that famous thing, no? What is the thing?
From the knee side flee to the elbow wide.
That's right, yeah. From the knee, I flee towards the elbow I grow. Yeah. D. Right? What do you think about D? Hmm? What do you think about D? Anybody? Ah, sorry. Can you hear me?
Yes,
Hello?
sir.
Okay, right, right. Uh, you can go through this, right? Growth pace is located between metaphysis and epiphysis. So nutrient artery, we know that story. Remember that exostosis moves away from growth ends due to muscle tension. Okay, it's muscle tension, and they have a malignant potential, 1% in single and 25% in multiple, right? Multiple exostosis, right? So for that, osteochondroma is an important differential diagnosis. So endosteum is pain sensitive, but periosteum is, right. That's why if you hit the bone from outside by a needle or whatever you are doing, it can cause a lot of pain, right? Right. This, can somebody answer?
A true.
Uh, Leads to enlargement of affected toe. Yes, you're right. You have seen in the ward, isn't it? These people, they have enlarged soft tissue due to inflammation and things. That toe looks really big compared to other toes. So that immediately you know that this patient has osteomyelitis. Okay. B.
True.
True. Yeah, pseudomonas is common in this type of people. C. That's why you often get green stuff in the ulcer, no, green discharge in the ulcer. C.
True.
True. Yeah. Bone, because it demineralizes, there's lysis. So structure is there of the toe is there, but you can't see the bone inside. Okay. You can't see the bone because decalcification, demineralization has occurred, and X-ray you can't see most of the bone. We'll show X-ray of that bit later. D. What do you think? Well, it's true. Amputation is, if you develop osteomyelitis of the foot, you have to remove that. Whether it's a toe or metatarsal, you can do a reamputation. You have to do that. Okay. There's no two words about that. If you develop osteomyelitis, but I had a discussion over this lecture with Dr. Harsha Mendis yesterday. What he said a very interesting thing. Although we see the bone at the base, we feel bone and we see the bone even at the base of the wound, that does not necessarily mean that patient has osteomyelitis. Even X-ray might show some lytic areas in the cortex and some periosteal reaction. It still patient doesn't necessarily mean that patient has osteomyelitis. So you may still try to heal that wound with soft tissue. Soft tissue healing, you must still try, right? Not necessarily mean that. It may be having, but not necessarily. Just because there is a periosteal reaction or elevation, just because there are some lytic areas in the periosteum, still we must try without amputation. Okay. But if you develop osteomyelitis, then you have to amputate. Right? So, because what he says is that is bone's reaction to surrounding inflammation. Bone's reaction to surrounding inflammation. What we see on the X-ray or in these things. So that's not necessarily osteomyelitis. E.
True.
True. Once calcaneum is gone, it has to be below. Okay. It has to be below, because these what happened to soldiers very often in this army. The landmine injuries, they lose anti-personal mine injuries. They trod on that, it blasts, and they lose their calcaneum. And then they think the rest of the foot looks viable, the toes looks viable, but that doesn't mean that you can have his foot. You have to cut it off because it's functionally not possible. Okay, somebody.
That actually depend on the cosmetic reason. Osteoma does not need.
You are right. Yeah, osteomas commonly you may have seen, I'm sure, occur in skull, face, and those things. So it is due to cosmetic reasons you need. Otherwise, so when you say osteoma really needs surgery, that's correct, isn't it? Hmm? Correct. Normally it doesn't mean it can normally on nag.
Yes.
Really needs surgery. You understand?
Yes, sir.
Yeah, because MCQ still you have to be careful about this wording. B. Anybody?
True.
True. Yeah, true. Chondromas is benign tumors of cartilaginous origin and you lay down cartilage, and it occurs in small bones, typically in the hands and even phalanges and feet, hands and feet. And what do you think the most likely DD, differential diagnosis of this? Because when you do X-ray, you can't see cartilage. No, you feel a firm lump, but when you do X-ray, it's not to be seen.
Gout.
Yes, gout is also can come into DD, you're right. But more commonly, what the most common firm lump you see in the hands and feet? You see in the clinic all the time. Ganglion. Okay, ganglions also can look like that, very firm. Now, deep ganglions can be fixed, like or mostly fixed, like. So it's kind of a DD. C.
True.
True.
Flat
It
bone.
commonly affects girdles and axial skeleton, the spine and axial skeleton, and the hips and the shoulders, that area. Osteochondroma. It's true, isn't it? E. Osteosarcoma.
False.
No, it's also true, right? Around knee. Answers. Right. Somebody answer this one. Anybody?
False.
Uh, well, it is the most common regime used, doxorubicin and cisplatin. Okay, don't answer that type of advanced stuff unless you have read widely. Okay, in MCQs you must not do that mistakes, right? This is not the thing to guess. B.
True.
It reduces the chance of fractures. Uh, yes, uh, it does. What are the problems with giving radiation? Any side effect? Radiation to bone? Hmm?
Necrosis?
Osteoradionecrosis. You are right. Right? It's not that common, but especially in the mandible area, it can happen. Osteoradionecrosis. That's called. It's a disabling condition where chronic discharge from the bone and also it's a messy thing. See, proton beam radiation hit the area according to the shape of the tumor. So these are, you are supposed to learn these things doing oncology appointment. You do oncology appointment, don't you? Hmm? Principles of these things, principles of investigations, all kind of investigation, and principles of treatment. Basic principle you should know. It's in your syllabus. Uh, we'll talk about that little later. What proton beam irradiation is. Proton are heavy things. They go follow a narrow area, so there's not much scatter outside. So they are focused. So they only affect local area. And also you can control the width and the depth of the damage, the depth of the damage, because uh, uh, they would not damage around, they would not damage beyond that. So a third thing about that is the maximum damage occurs where the beam stops. So you can adjust these things, taking this into consideration. When tumor is deep inside, you can adjust the width of the beam and the depth where it will penetrate exactly on the uh, area of the tumor. So you can give a dose to the tumor without hurting tissues around or tissues on the way or tissues beyond. So this is external beam therapy. Normally problem with external beam is you get whole body get irradiated. But this is advanced form of external beam therapy, right? External beam therapy, which is really beneficial for the management of tumors, which is very good. We can exactly burn the tumor. So that's a really advantage, right? Real advantage. But it doesn't act by, it can't do this much of thing act according to shape of the tumor. This is something else. We'll talk about that bit later, right? So bone sarcoma necessitate amputation.
False, sir.
False, yeah. We have discussed several times. Now you have the idea. If you diagnose them early and we do MRI and all that to see the spread. If they are confined to one compartment, single compartment or something, they don't need amputation. But if they have spread too much or they are too proximal or they involve vessels and nerves, the tumor involves vessels and nerves already, then they will need amputation, right? Final one.
True.
Uh, Not really. You know, you now this is not advanced thing. This is common sense. There are some things you can answer with a common sense. Some MCQs, right? The methotrexate, what is a targeted chemotherapeutic agent? Targeted ඒක නිකන් අලුත් development එකක්. හරිද? Targeted chemotherapeutic agent කියන්නේ නේ, there are various things, but they are a new one. Methotrexate is a very old one. Even when I was student, methotrexate was there 35 years ago. Right? So it's not a targeted one, all right? Let's answer, go through the answers. Right. Now, this thing, the number C, please make a note of that and study in the internet about what these things are, right? I think I just told you what PBI, proton beam irradiation, is. Then the other thing is intensity modulated radiation therapy, right? Must know the basic principle, just like I described, what I described, right? So that's called Bragg peak. Bragg peak effect, the name of a person, where the beam stops the maximum, that's where the maximum damage occurs, right? There is a lot of physics into it, right? Now it is like this. I have to have a better contraption next time. Right? It is not really good. Now supposing now these radiation beams are like bullets, okay? Bullets. If a bullet goes through the one, right? Through the one quickly, right? Quickly through a soft tissue. Now energy which you lay down will be minimum because this is V1, this is V2. So it has passed very quickly. So difference between V1, V2, right? Have you heard of this half MC square? Hello?
Yes, sir.
Yeah,
Yes,
half
sir.
MC square, Chalaka Shaktiya to Vibhava Shaktiya. Okay? Kinetic energy to static energy transfer. So during path of this bullet, this happens. So half MC square, right? Mass doesn't change. Mass will go to anyway. Right? C is velocity, right? So velocity, how it works is that if it goes quickly, V2 divided by V1 or will be less. But if it stops here, this is a theory about it. If it stops here, then this gap between this will be much more, and there will be most of the energy is dissipated here where the beam stops. Okay, most of the energy is dissipated there where the beam stops. So it is a sort of a very rough way to explain what's called Bragg peak effect. Sorry. Don't get frightened by these things, by machines or new machines or these new words or complex words, right? It's a basically simple physics underneath. You go to the internet, you can find out. So I want now you to be different. Otherwise, this mountains ahead, it will be very difficult. You have to learn to think by yourself, study by yourself, and go through the internet and clarify these things by yourself. Okay, that's a major thing which is lacking with us. Okay, can somebody answer this? Anybody? Hello? Can you hear me?
Yes, sir.
Yes, the first one has to be giant cell. But
Yeah.
answers are there, sir.
Sorry, it's my yeah, that's right. So bubble appearance is a giant cell, converse triangle, and it's a bone cyst also. It's there. So you have seen the answers, so we'll go to that one. Moth-eaten appearance is in osteoclastoma falls. Yeah, it is secondary tumors. It happens, lytic type of secondary tumor. Secondary tumor metastasis also can show on the X-ray with 2 or 3 different types: lytic, permeative, So like that, okay? Permeate pattern. Uh, it's in leukemia, but it's also true for even sarcoma also, right? And the cyst in the distal radius, they do not extend. Normal benign cyst would not expand the distal radius, but would not extend beyond the epiphysis, right? So one important thing you must remember is these things like Codman triangles are were not only for osteosarcoma, although we used to think it that way. Yeah, I haven't corrected these answers are there. That's fine. Telepathic point of errors. I just put this question to know that there are many other little orthopedic conditions, pediatric conditions, things which you have to know. Okay, telepathic point of errors. It affects males. Uh, 4 to 1. Uh, but then it's false. It's 2 to 1. Bilateral in about 50%. I'm going to the correct answers only. Parent with cup would have 25% of having a child with the same, and Achilles tendon lengthening is required. Uh, that's true. You have to do very much lengthening. Soft tissue release, that's called soft tissue release. And not only Achilles tendon, the other tissues and those things. Uh, and aggressive physiotherapy, very standardized physiotherapy regime for these children. And Des Brown splint is beneficial. That is actually false. Des Brown splint is for something else. I'm not 100% sure, but I'm sure it's false. Although it says true here, it's for something else. It is for, I think, congenital dislocation of hip. This brown splint, okay? Dislocation of hip. So, what is the test you do to detect congenital dislocation of hip? Otolani's test, clinical test. You do that. You feel a click, nail. Otolani's test. And then other area I forgot to mention in my lectures is limping child with a limp, unilateral limp, right? That's a very important thing we have to discuss. I forgot to mention it actually. You please read about it. So there are few different conditions, which can lead to this, and depend on the age group, they can vary. Depend on the age group, right? Uh, and please go through this clinical case of a child with a limp, right? The important thing there in management is when somebody has a limp, you first you never allow him to walk. And father will come saying that my child, a 10-year-old child, is limping for last 1 week. So first thing you do is immobilize. Never allow him to wait there. Admit the bugger into the hospital and put him in a bed, right? Put him on a bed, and then you do X-rays, investigations, you do everything after that, right? Because if child is limping and you allow the child to walk, it can permanently damage their hips, right? It may be slipped upper femoral epiphysis, or it may be transient synovitis or irritable hip. It, it could be osteomyelitis of some sort. It could be many different things. So about 5, 6, 7 DD come into picture with a limping child. But that's a very important clinical presentation, a common and important thing which you have to know a lot about, which I forgot to mention here. Right? Okay, can somebody tell me what this is? This patient has a discharging sinus from time to time here. So what is the diagnosis? We are not talking about management. I just want to know this is what it looks like.
Chronic osteomyelitis.
Yes.
TB osteomyelitis.
Affecting which bone? Which bone?
Tibia.
Tibia.
Tibia. Yeah, it is tibia. No, that's right. Chronic osteomyelitis affecting tibia. So management of chronic osteomyelitis, we mentioned. We do a ESR, we do X-ray and the features, and then you think about IV antibiotics and surgery and various other big options like removing the bone or putting artificial bone, endoprosthesis, all these options you have to consider in life. Now, what do you see? This is the same patient on the X-ray, on the tibia and fibula X-ray is of the same patient. Do you notice anything unusual?
Mid shaft enlargement.
Yes, mid shaft enlargement. Very good, right? So mid shaft is abnormally enlarged. Otherwise, they should look smooth like that, no? Here it's abnormal enlargement and also some thickening of the mid shaft, more white. Okay, bone marrow, that nice feature of bone marrow. Now you look, if you look at other bone, you can see the bone marrow goes nicely like that bone marrow. Eh? Here it doesn't. Eh? They're all thickening of the bone, right? And the enlargement, actually, in fact, there's periosteal reaction. So this is what you get in osteomyelitis. Okay, you have got in osteomyelitis. So you know that patient has chronic osteomyelitis, bone changes. Along with the clinical picture, you tell it. Now, this other X-ray is of a diabetic patient with the ulcer over the lateral side. What do you see?
Bony damage, sclerosis.
Yes, so that is ghost bone, right? This is ghost bone. Bone is gone, like, but it's there, but lytic. So there's lysis and the bone damage. This is what you call ghost bone, right? Or lytic areas. Okay, right. Give me about 4 or 5 differential diagnoses for this one.
Septic
Septic
arthritis of the knee.
Septic arthritis, first thing that I told you, SCP, serious common pitfalls. Most important thing is serious thing you have to think first, right? More serious thing.
Cellulitis.
Yeah, cellulitis is one. Good. Septic arthritis is one. Then prepatellar bursitis, infrapatellar bursitis, and sympathetic effusion. Okay, sympathetic effusion. So those are the 5 important DDs you have to consider before examining. Spot diagnosis, right? Before you see that, whenever you see it within 2-3 seconds, these 5 things should come to your mind for rest of your life. Then you can work out the rest. What do you think about this?
What disease?
Yeah. What's disease? So all goes with that, isn't it? Third year, the state work, cervical lymph nodes, everything. You can see the destruction of the bone, right? You check the bone, and there is a what is called, there is a kyphosis here, right? Isn't it? Kyphosis is there. Okay, curve is not smooth, and there will kyphosis. So if you have extreme kyphosis, what do you call it? Gibbous. Gibbus, gibbous. You have heard of that? Severe kyphosis of the chest.
I think it is some kind of angle, no, sir? Gibbous angle or something.
Gibbous killer name. It's a common word they use. I am not 100% sure, but I think it's a word they use. They may be using angle also, name angle also, but gibbous, they're similar sounding word probably. They call that when the thoracic spine is like that at an angle. We'll check that up later. So what do you think about this one?
Multiple myeloma.
Sorry, very good. It's a multiple myeloma. So it's a common condition, relatively common condition. So you have to be concerned about these things. You have to diagnose, you have to suspect, you have to diagnose with people with back pains. Okay, especially after 40-45 years, they come with back pains. They might say they have a trauma, you have been working hard. But don't go by that. You always go by your proper training and think of common things, think of serious things first, and then common things. So multiple myeloma should come to picture. You can see the multiple levels of destruction. Multiple levels of destruction here. X-ray of the same patient. You notice anything?
It was all appearance.
Yeah. Sorry?
Pepper pot.
Yeah, you see these holes, no? You see these holes. Pepper pot appearance. Yeah, pepper pot skull. Right. What do you think about this?
Osteosarcoma.
Yeah, it looks like osteosarcoma. These are these sun-rays spicules, right? These sun-rays spicules, it looks like osteosarcoma, right? This is sort of like you can see the translucent area in the bone, and periosteum has got shifted a bit, so you get Codman triangle. And the permeative margin, මේක නිකන් අර වලාකුළු වගේ blur වෙන margin එකක්, okay? Permeative margin and the lesion here, right? What is this? You saw the previous one, how invasive and aggressive looking that was. This is of a longer duration. Again, a lump about knee or pain about knee. Lump the multiplication of cells, right, are common. So epiphyseal plates, epiphyseal plates, these are the areas where multiplication of things are common. And because growing ends are nearby, so there's one reason. It's not the only reason, but one reason why these tumors, they occur in young people and they occur in near growing ends, and that's why they happen around knee. So any problem with knee, young or old, you do X-ray and see what it is, right? Do X-ray and see. So this is a giant cell tumor. This is the most typically characteristic giant cell tumor, isn't it? What do you call this? By the look of it?
Soap
bubble.
Soap bubble appearance. That's right. Soap bubble appearance. Yeah, that's a typical of what do you call classical presentation. Yes, I told you there are two things. One is a classical presentation of something and typical presentation. Classical කියන්නේ නිකන් අර සාහිත්‍යේන ඒ වගේ නිකන් typical sort of this interesting kind of a thing, right? Like if Carpenter who present with hematemesis, unilateral epistaxis is nasopharyngeal carcinoma. That's called classical presentation. But typical one is not that. Typical is what's common. And the common one is common presentation is this, what you see on this X-ray. Okay. So any presentation you must know both, right? You must know both. Like scrotal carcinoma, they used to call chimney sweepers scrotum, no? Scrotal carcinoma, because the people in the old London, they used to go along chimneys to clean, and that burned out material acting as carcinogens, touching the scrotum and everything else and producing cancer. Anybody? I enlarge it a bit for you. You see the bone, what do you see? Periosteum has elevated, isn't it? Can you see that?
Is it onion peel appearance?
Yes. Yeah. Then onion peel කියලා onion වගේම ඉන්නේ නෑ ඕක. අපි දැන් බලාපොරොත්තු වෙන්නේ typical thing no. You get of course, but you must know more subtle things, subtle ways of being presenting. So one of the important clues here is about Ewing's is that it happens towards the middle of the bone, right? not in the middle exactly, but towards the middle. Because other tumors, as we have seen, they happen at the top end, isn't it? In this area, right? Ewing's tumor arises from diaphysis, right? Mnemonic is that epiphysis, metaphysis, and diaphysis. EMD, Emergency Medicine Department, right? You can remember that, right? And diaphysis. And so so it is Ewing's sarcoma, yes. What is this? What is the difference? I mean, okay, it's what do you see here? Anybody? This again, what you see? There is a damage to periosteum. There is erosion. There are lytic areas. You can see there are some lytic areas. There is, as we mentioned before, sunray spicules. Okay, sunray spicules. Okay, you can see sunray spicules. You can see some lytic areas. Right? So I think probably even Codman's triangle here. So this is, but age. What do you think about age? 58 is fairly old, Neil. I'm also near 58, but it's true, right? It's old, right? So what do you think this is? In an older person, it's a osteochondrosarcoma. Osteochondrosarcoma. Age is the answer, right? Age is the answer. And what is this?
Osteochondroma.
Yes, exostosis. It's osteochondroma. You're right, right? It is a it's a exostosis. It's a same name. Sometimes they use these names together. The exostosis. So that's of the shoulder. Can they become malignant?
Yeah, chondrosarcoma.
They can. Yeah, that's right. Yeah. They can become malignant. Especially the hereditary multiple exostosis. Right? Even these ones have 1% chance of getting malignant. But if they have a hereditary multiple exostosis, chance of one of them become malignant is 25%. Right? 25%. Right? With multiple exostosis and say patient with multiple exostosis, the single no, multiple exostosis present with bleeding PR at 15 years. You find patient present with to be a 15-year-old boy bleeding PR and ask multiple and change of bowel habits, some mucus with blood and multiple exostosis. What is the diagnosis? How you connect the two things?
Does bleeding lead to hemangioma, sir?
Nah, Gardner syndrome. Right? Write and read about it, sir. Gardner syndrome. That's the thing we ask in the exams, huh? Final MBBS, so long case, what do you call long case in colorectal cancer, like. So if you tell these things, you will get, like go to distinction level. We talk about Gardner syndrome. Okay. Last one.
Osteoporosis.
That's what, when this kind of patient presented to our ward recently, that is what the doctor saw. So unfortunately, that's what doctor thought. Somebody who had a look, I didn't have a look at the x-ray, but somebody who had a look thought that. I always tell you when a presentation comes, think of more serious first. Even though it likely to be rare, what is the most serious which can be of this presentation? Then what's common, and then pitfalls in that area, any particular things special things about that presentation, that type of presentation. So what is the most serious one it can be?
Multiple myeloma, osteos.
No, multiple myeloma is the back pain. No, it's commonly with back pain. Right? When you look at this fracture, what do you see about the edges? Lytic. They are lytic. In osteoporosis fractures, it's straight damage, right? Edges are straight cut. Okay, they will be demineralized bone, but they are straight cut. Now here you have lytic area. You can see this round area, no? මෙහෙමනේ තියෙන්නේ මේ වගේ like round area, right? So lytic, that is lytic areas are due to secondary bone tumor. This is how they look like, and it's a common site for breast cancer to metastasize. This patient in the X-ray we saw, patient was diagnosed of having the breast cancer, which has spread to bone here. Okay, so minor trauma, while walking, hitting, that's a minor trauma, so obviously pathological fracture. And because lytic areas, it's a secondary bed. So first thing was think of more serious of this presentation is the metastasis, bony mets. And then you think of osteoporosis, like you said, though it could be even a bony cyst, benign thing, whatever. Right. Okay, I think that's it for today. I think we covered the fairly important areas, fairly common and important areas. Must know, could know, and some should know, must know, and little bit of could know knowledge in orthopedics. So I always tell you as my final thing, out of general surgical subjects, vascular, urology, and orthopedics form a heavy component, other than what we call general surgery, what you see in Profinit. So read widely and see more cases in these areas. In the exams as well as in the clinical practice, they will be very useful to make a very good doctor and concentrate on these three areas. Read good books, solid theory books on that area. Okay, right. So we'll meet later at some stage. I think from next week, somebody else will be doing the lectures on different area. We will tell you. Please follow these things, our lectures and things, because otherwise you can become lazy and your mind can go wandering, and so better to follow all these things and keep updated. Okay, so we'll do question answer session and everything. So last Tuesday there was a problem with our transmission. Only our A&E registrar Ishan managed to give his lecture. I want to do some MCQ, then he has finished the thing, and there was difficult transferring, but we'll technical deficiency will overcome in time. So okay, right, good day to you, good night.
Thank you, sir.
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 Welcome.